Good day, everybody. We are going to continue on the talks about ethics in obstetrics and gynecology, and this is the second part of it. We are going to take certain issues which you will encounter during your practice, and we show some light on how to deal with them. The contents of our talk here will be assisted reproductive technology, treatment of infertility by in vitro fertilization plus embryo transfer, fertility preservation, gamete and embryo donation, surrogacy and gestational careers, research on embryos, ethical guidelines regarding sale of gamete and embryos. Are they a commodity? Is it an industry now? UN Convention on the Rights of Persons with Disabilities, whom we will see in our practice, and pregnancy and HIV positive patients. So we'll talk about these issues during this talk. Assisted reproductive technology used to be called test tube babies. All it entails that you get an ovum from a lady, fertilize it in the laboratory by sperm. It stays for some time in the laboratory, then it will be returned into the uterus of the lady. We call it in vitro fertilization and embryo transfer, or assisted reproductive technology. There are other parts of it, or other types of assisted reproductive technology, but we are going to deal with this mainly. Historical background. I'm sure you have heard about the sheep Dolly, and when it was, she had been cloned from another sheep. It came at a history at that time. Before it and after it, the field of reproduction has developed so rapidly. Before it, 1950, sperm from an ox were frozen. So they collected the sperm from an ox and they freeze them. Probably they are going to do intrauterine insemination to the cows. 1978, a film called Boys from Brazil. At that time, it is a film with the idea that everybody in that film could become a genius. That's to say, they take a genius person and try and create people from him, not by cloning at that time, probably by other methods. 1978, Louis Brown was the first IVF, in vitro fertilization, baby to be born. 1985, there is a genetically altered animal, and 1996, Dolly. 2002, an organization called Clone Aid, they allege that they have cloned the first human being. I'm cloning from the human being, what they called her Eve. That tend to be not true. So this is historical. Assisted reproductive technology, for us as gynecologists, usually 1978 is the year that marking the development of management of infertility in general by what is now quite commonly used. And that's the birth of Louis Brown in 1978 through in vitro fertilization and embryo transfer. That's to say, the fertilization has taken place in the laboratory. By two people. Howard Jones is the physiologist, or the one who did all the technical laboratory part of it. Patrick Steptoe is the gynecologist or the obstetrician. Howard Jones put this statement now. He put it saying that 11:47 p.m. Tuesday, July the 25th, 1978, was surely a unique moment in the life of Patrick Steptoe. This was the hour and minute he delivered Louise Brown, the world's first baby, meticulously, lovingly, and aseptically conceived in the laboratory, but popularly referred to as the world's first test tube baby. Historical development by these two gentlemen, Patrick Steptoe, the gynecologist, and Howard Jones is the physiologist who did all the embryological work on it. So infertility nowadays, millions of couples are affected with infertility. IVF, in vitro fertilization, gives hope to millions of couples suffering from infertility. Introduced, it gives hope to the women, but it introduced so many challenges and issues, ethical issues, legal issues, and social challenges. So we have to deal with this as gynecologists or as obstetrician or as scientists because it includes all of us. This is the reference of the statement. So issues occurred around it. Issues concerning assisted reproductive technology focus on drugs to be used because we give the woman drugs so that the ovaries produce many ova, and we collect many ovaries from the ovary of the lady. Normally, it is 1 or 2. If you give them drug, you can get up to any level. 10, 20 you can get. So that is drug. How safe are the drug to the mother to be? Transparency of pregnancy data from clinics. Confidentiality and privacy should be there. So how transparent are the clinics with it? How honest are they in it? Addressing economic barriers. The number of embryos to be transferred. I remember in the last talk, I said embryo reduction. Now, most of places will see that you retain, fertilize in the laboratory how many, but you retain embryos into the uterus, 1 or 2. Some people use, as I have said, to retain into the uterus so many, resulting in multiple gestational problems. With legislation defining practice, are there any laws or legislation in any country? It is there, it should be. Issues detailed accounting for ART reporting and regulations across the globe is available, International Federation of Fertility Societies. So these are issues ethically, socially, legally have come up with the assisted reproductive technology. The multiple gestational pregnancy, if you put more than one and all of them have implanted into the uterus, then she will end up with multiple pregnancy, either twins, triplets, quadruplets, as many. That has problems to the mother and to the fetus, both. Systemic disease to the mother, okay, gestational diabetes, pregnancy-induced hypertension, antepartum hemorrhage, polyhydramnios, anemia, etc. So with multiple gestation, these are the possible problems that could occur to the woman. Prematurity to the fetuses. Multiple pregnancy usually have premature deliveries. And a premature child is all what you need to do for. Cost to the health system. Thus, legislation to the number of fertilized ova per cycle. How many cycles, how many ovaries, how many ova you will get from the ovary and you fertilize them. There must be legislation for that. The number of ova to be fertilized. Limit the number of embryos to be transferred. After fertilization, you limit the number of the embryos you are going to put back. The number of embryos cryopreserved. And as we will see, you may fertilize several ova. You have to retain one or two. What to do with the rest? They are already fertilized. What we advise or sometimes do is cryopreserve them. يجمدون يحفظون till they come to it next pregnancy, for example. So how many? The legislation should be how many embryos to be cryopreserved and for how long? سنة, سنتين, 3, 4, 5 years. They have to be a law that deal with these problems. And it started to be there. Other issues concerning assisted reproductive technology is inequitable distribution of access to care. Not everybody can afford it. Those who are well off can afford it. It's quite costly. There is an economic barriers to it almost worldwide in any part of the world. So those who can afford it, they can do it. Others, though they need it, indicated in their case, but they can't do it. So, question being put, should the government pay for the cost? This is an infertile couple. They went through so many investigations. It is their right to have a child. Then they can't afford. Should the government pay for that? Or should the government pay to prevent and treat malaria and reduce maternal mortality and other common issues? This is an issue which is occurring now. Answer till now, the government does not pay for it. It's being done privately, those who can afford it. We mentioned something about pre-implantation genetic diagnosis in our first talk. It should characterize the genetic composition of embryos prior to embryo transfer. In the laboratory, after fertilization, in the laboratory, before putting them back into the uterus, you decide their sex, male or female. So sex selection in the proper setting may offer a substantial health benefit. That's in whereby you prevent sex-linked diseases. Transfer only embryos of certain sex may confer a therapeutic benefit if used to avoid a known sex-linked disorder. So we do PGD, pre-implantation genetic diagnosis. We know the sex. We transfer the sex that does not carry with it the disease. That will give to substantial health benefit for the family, for the community, for the nation. Sex selection, purely for the preference of the parents, could conceivably, if practiced on large scale, skew the gender proponents in certain nations where one gender when one gender is culturally preferred. That's to say, it will be either most of the society are males because they don't prefer females, and so from the start, they decide their sex and they don't put them back into the uterus, or the reverse. Usually, or unfortunately, it is the female who is vulnerable. The possibility that in the future technology will permit manipulation of genetic material within the embryo is work there. So for that, if we could reach a stage whereby we could manipulate then the genetic material affecting the disease, that could be a solution. Fertility preservation. We talked about assisted reproductive technology and issues resulting from it. Fertility preservation. We know the female fertility decreases with age. the female baby will be born by all the number of its primordial follicles. And when she reaches adulthood, during each menstrual cycle, several of them will start to grow. One or two will outgrow the others, become mature ova, and they will be released as ovulation, and the ova will be either come down with the menstrual cycle or fertilization may take place. So she had all the lot of her follicles. By age, they will decrease, and they reach a state whereby they say the age of 45, 50, menses stop because there are no eggs in the ovary. The male continue to produce sperm till his death. That is the difference. So what shall we do for the female? One of them is natural decrease. But there are certain chemotherapeutic agents which are used to treat cancer. They are toxic to the ovary and result in diminished ovarian reserve and reduced fertility. A lady had cancer, given therapeutic agents, those will affect the ovary, reduce the number of follicles in it. So eventually she will have a problem of getting pregnant. So multiple techniques were put, including oocyte cryopreservation. They get so many follicles, so many ova, mature them, and they get them out, cryopreserve them till the mother or the woman needs them. Or you preserve strips of the ovarian cortex. Take some part of the ovary, then preserve it, cryopreserve it for the lady when she needs it. With subsequent reimplantation and stimulation showed some pregnancy success. Multiple techniques, including oocyte cryopreservation and preservation of the strips of ovarian cortex with subsequent reimplantation and stimulation, showed some pregnancy success. So these procedures have been tried to preserve the fertility of the lady. Many have suggested that prior to being treated with cancer, that is a suggestion now accepted by many, a lady with cancer, prior to treat the cancer and give her medications, we should offer fertility preservation measures, in vitro maturation, oocyte vitrification, and freezing of intact human ovaries with their vascular pellicles. We preserve this so that if the lady needs them, or when the lady needs them later on after treatment of her cancer, her own tissues are there and they could be stimulated and get some ova from them, do an IVF assisted production technology. So we go and see another problem ethically about reproduction, gamete donation. Gamete means either a sperm or an ovum. The sperm donation can be traced back up to the 80s, the beginning of the 19th century, up to 1800. In 1980s, oocyte donation was introduced. Women donating oocyte must undergo IVF. That's to say, a lady will have some oocytes taken from her. She will donate them to X couple. Oocyte donors or donation should be voluntarily, without any coercion or undue influence. Financial compensation of oocyte donors may lead to exploitation of women. That's to say, women give their ova through IVF. You give her drugs, the ovaries will produce so many ova. You aspirate this over, and she donates them to X, Y, or Z. So if there is compensation in that, it will be a business. It will be exploitation for her. We'll come to this in a minute. The other thing is anonymity of the donor should be preserved. Whoever takes the sperm or the ovum, the donor should be anonymous, not known to them. Otherwise, problems may occur. Embryo donation. In the last slide, we talked about the ovum and the sperm. Here it became an embryo, fertilized. Fertilized ovum become an embryo. Would you donate it? Surplus embryos are produced in IVF clinics. As I have said, they fertilize so many ova, and a lot of them will be fertilized. Some of them will be suitable, but they could only put back into the uterus of the couple or the lady, one or two. So they are excess. What to do with them? What to do with this excess? 4 possible fates. 1, thawing and discarding. That's to say, you leave them on the bench and they die, and that's it. You do nothing for them. Donation for research is an embryo formed now of so many cells. You can give it for research. Indefinite storage, cryopreservation. As we have said earlier on, there must be a law to tell for how long should the fertilized or ovum or the embryo be cryopreserved. So indefinite storage or donation to another couple for the purpose of uterine transfer. So either you leave them on the desk, the fertilized or the embryos, they die, that's it. Or you donate them to research, or you donate them to another couple, or you cryopreserve them indefinitely, or after a certain period, the couple will come back and take their embryo, which has already been cryopreserved. So this is an issue. Another issue you deal with in assisted reproductive technology, surrogacy and gestational carrier. استئجار الأرحام أو الرحم الضئر. And there is a difference between surrogacy and gestational carrier. Surrogacy is defined as the woman who agrees to carry a pregnancy using her own oocyte, but the sperm of another couple. And after delivery, she will give the child, relinquish the child to this couple upon delivery. That's to say, she has the ovary, she has the ovum, the ovum is hers, fertilized in the laboratory by the sperm of another couple. After delivery, she gives them the baby. This is surrogacy. Gestational carrier, the couple undergoes IVF with their genetic gametes and then places the resultant embryo in another woman's uterus, the gestational carrier, who will carry the pregnancy and give the child back to the couple after being delivered. A difference here, أنه both the ovum and the sperm are from a different couple. They will hire another woman's uterus to carry the pregnancy for them. All the genetic materials is theirs, and after delivery, she should give them the child back. While in surrogacy, part of the child is the woman's ovum. So there are problems now arising with it. Currently, the use of gestational carrier is far more common than that of surrogates. That's to say, a couple get their ovum and sperm, fertilize them in a laboratory, and ask another woman to carry the fertilized embryo till all through pregnancy, and after delivery, give them their child. A lot of problems had arisen. They went even to the court because the gestational carrier have the feeling and the contact with the child all through the 9 months. She had a feeling that it is hers. She may not give it to them, and a lot of problems has taken place. This is the reference. Surrogates and gestational carriers are subject to significant medical and emotional risk from carrying a pregnancy and undergoing delivery, is what I have just been saying. They both carried the child through the whole pregnancy. They may have some problems with it, medical problems related to the pregnancy itself. They have had delivery with it, whether it is vaginal or cesarean section. So they are emotionally linked to that. Extensive counseling and meticulous informed consent are required. You tell them beforehand to try and reduce this. It is a form of child selling or the sale of parental rights. If it is a surrogate, the ova is hers, the sperm is from somebody, she is selling them the bag because it's not for free. She carried the pregnancy for money. So is it a child selling or is it the sales of parental right? She got carried with it, got pregnant with it, carried till the end of the pregnancy, and is it her right not to give it? Issues unresolved internationally about gestational carriers and surrogacy, issues of individual rights. As I have just said, she had a feeling that this is her baby. She carried it for 9 months. She received it either as a sperm or as an embryo. Commodification, is it a commodity? سلعة تجارية. Exploitation, استغلال, exploitation of women. Citizenship of the offspring of international gestational carriers. Whether, as you will see in the next slide, gestational carriers could come from the Western world. Sorry, the couple could come from the Western world, and the gestational carrier could be in another part, in another country. And this was happening now. So the citizenship of that born child. Trade, fair trade. Is it a trade, as you will see? Is it an industry? Surrogacy, استئجار الأرحام. Is it an industry? You may think of it that way, because it's not for free. The couple will give the gestational carrier or the surrogate mother payment for that. She's going to carry the pregnancy for 9 months and eventually will give it back to them. So it is for payment. Thus looks like an industry. The mean compensation for a gestational carrier estimated at United States of America about 20,000. That's in 2008. The figure could have changed now. 20,000 in the States, while it's only 4,000 in India. So why not the couple come from the United States and they hire a uterus in India? يبقى the gestational carrier is from India, just for $4,000 given to her. Due to these financial and legal considerations, international surrogacy has emerged as an emerging industry, especially in developing countries. That's an ethical issue to be dealt with. We go to another issue, embryo research. The embryo, as we have said, the fertilized ovum become an embryo in the IVF clinic when it could be donated for research or donated to a couple or left to die or cryopreserved. So why is being given it? Because the embryo have stem cells, and these are undifferentiated cells where they have the ability to self-renew and to differentiate into one or several cell types. Undifferentiated now, but with certain treatment and management, it could be differentiated into the pancreatic cells to treat diabetes. They could be differentiated into brain cells to treat Parkinson's disease. So this is stem cell research. It's a big issue. Like in here, the embryo comes into it because the stem cells could be from the clinics, IVF clinics, or other, I beg your pardon. So stem cells may be derived from the embryo in the IVF clinic, from the cord blood of a lady, from the fetus, or from the adult. From all of them now, we can create stem cells and make those stem cells to be differentiated into the cells we want. And that's now a wide area of research going on for ages now, and a lot of success has taken place. So here we are dealing with the embryo. In the human, these cells may be obtained from supernumerary embryos till IVF clinics. Embryos created de novo from donated gametes. They give you the gametes, ovum and sperm. You fertilize them. You develop embryos from them purely for research, not to be transferred back into the mother. That's happening in some places. Or possibly embryos cloned by somatic cell nuclear transfer. ودي زي الكلونينج اللي جبناه في دولي early on or clone 8 they have a lead that they did some cloning of a human by somatic cell nuclear transfer that is taking the adult cell. So in the human, this is where the embryos could be brought and they could be subjected for research. It is important because we have to further improve fertility treatment if we do research on it. Not only that, now we are combating many diseases. We believe that research, stem cell embryos, stem cell could be used to treat diabetes, Parkinson's disease, spinal cord injury, and others. And already research has gone into that. So these embryos could be used to treat these diseases. Shall we accept that as ethical and proceed with it? Or shall be there some constraints? Or shall we say it shouldn't be done? Allowed in certain situations. When the consent of the couple should be taken, embryos should not be created for purposes of research. Women must be protected from coercion or undue inducement to donate oocytes. She may donate an oocyte, somebody will donate a sperm, they create an embryo just because to do research on it. So it shouldn't be for research. We have to have the informed consent of the couple who made it so that they can accept it to be done for research. So we have some ethical guidelines for the sale of gametes and embryos. What are these guidelines? We believe that the donation of genetic material should be altruistic and free from commercial exploitation. It should be for free, altruistic, no money being paid for that, amal khairi, free from any commercial exploitation. If you are going to give an embryo for research. Reasonable compensation for legitimate expenses is appropriate. Compensation for certain situations which are logistic for her to travel to do some certain things are acceptable, but not the price of the embryo or the gamete. Some centers offer IVF cycles, sterilization, or other medical treatment to women in exchange of donation of oocytes, happening in some parts of the world. They tell the lady, you give us oocytes, we'll give you drug. You give us after that, we aspirate the ova, and you donate the ova or the oocyte for us. We'll do sterilization for you for free. Or we'll give you a cycle, IVF cycle, in vitro fertilization cycle, provided that you donate the oocyte to us or provide the embryo to us. This is considered to be payment and unethical. الثالث ده. احنا قلنا the stem cells could be brought from the embryos or the clinic or from the cord. The cord blood contains stem cells, useful in transplantation for patients with a range of malignant and hematological conditions like leukemias. What they do now is that they get the blood from the cord, they store it in a bank, blood bank or cord blood bank, and when you need it, you come to it after so many years. Of course, you pay for the procedures كلها, and you pay for the storage. There is a law because you can use it. There are stem cells in it. For example, if the donor of the blood, cord blood taken from the baby, stored for him or her, few years later or many years later, she had a disease. So they could use her stem cells stored to treat that disease, especially something like Parkinson's disease, spinal cord injury, diabetes, etc. The list is now increasing for diseases that could be treated by stem cell. So here, because there is a low incidence of graft, there's this host reaction on a viral disease. It is his or her stem cells. No reaction is expected to occur. Being stored for so many years for her. Appropriate and non-coercive consent and counseling of a mother-to-be and her husband when you take it. You make sure that early cord clamping for the purpose of collecting cord blood should not be done if there is a risk to childhood anemia. Cord blood banking is happening now worldwide. In Europe, it is there. And I tell you, I have been approached in the Sudan to be part of a group to do the blood banking. All what we need to give them is cord blood. Obviously, it is a trade. They are going to store it for certain conditions, and the donor of it or the child is known. Whenever he or she needs it, it will be given back to him or her as stem cells. From there, they develop what they want. So it's going to be some sort of an industry. It is already. But for that reason, we shouldn't take much cord blood till the child gets anemia. Cord blood banking should be organized at a national or other public level with a publicly accountable body, not to be left to the private industry or trade. Just before we finish, Convention on the Rights of Persons with Disability. Human rights law, international legal effect on disability. What is a disability? And accordingly, they have the right to be treated. Defined as an evolving concept that results from an interaction between persons with impairments and attitudinal and environmental barriers that hinders their full and effective participation in society on an equal basis with others. So hindering their full participation effectively and they have bias against with any disability they have. So having that disability, the convention recognized that women and girls with disabilities are often at a greater risk of violence, injury, abuse, neglect, or negligent treatment, maltreatment, or exploitation. It is practiced. So the convention here is trying to protect their rights. Vulnerability is aggravated by their pregnancy. She may have some disability and she may get pregnant. So she will become very vulnerable due to the pregnancy. And that may result in great dependency on the obstetrician or the gynecologist and related health service. Disabled persons' right to found a family on the basis of free and full consent. She is disabled with whatever sort of disablement. She has the right to form a family, and we have the right to treat the health care. She should have equal access to health care, including in the area of sexual and reproductive health. So the convention defining the disabled women or girls, if they come obstetrically, we have to deal with them like a normal patient. We should not deprive them of any medical care or give them an inferior medical care. Health professionals provide care of the same quality to persons with disabilities as others. The promulgation of the ethical standards for public and private health care is another article. Discriminatory denial of health care or health services should be on their disability should be prohibited. Prohibits discriminatory denial of health care or health services on the basis of disability. I think I'll give you another case to finish our talk. Rania is the case scenario. Rania is engaged to Rashid, a successful young businessman, and the marriage set for the 25th of May 2023, 2 years back. January 23, while you are working as a doctor in the outpatient department, Rashid presented to you with fever and vomiting. He was given treatment for malaria with no response. So he was admitted to hospital and they did a detailed investigation on him, including CBC, renal function test, liver function tests, VIDAL, and HIV screening. The VIDAL test was positive for enteric fever, to which he was given treatment. He responded to the treatment and eventually discharged and resumed work. The doctor then informed him that he is an HIV positive, human immunodeficiency virus. So after telling him the result, he himself confessed that he knows that he's an HIV/AIDS positive and he's an active member in the group of people living with HIV/AIDS. He knows himself and he's active in the group who are trying to support each other. اسمها group people living with HIV. Rania and her family, الفيانسيه بتاعته, they were following him while in his hospital and they know that he had enteric fever and he is now well. Would you tell Rania about Rashid's HIV condition? That's patient rights. As a doctor, should you tell the fiancée, her name is Rania, that your husband-to-be is an HIV positive? Patient rights, you shouldn't. But you encourage the patient to tell the fact to the couple, or sorry, to his fiancée or the family. He himself should tell them. Because his right, we have to keep confidentiality. And here comes the balance between privacy and confidentiality and the injustice. You as a doctor, you will put it on the other couple without telling them. So you are endangering or putting them in danger of affecting the disease, but equally, the confidentiality and privacy of the profession won't allow you to do that. Here you have to have the balance, and we usually encourage the patient to tell. Going on HIV/AIDS positive patients, they come to us pregnant. They must not be subjected to denial of care or to inferior care on the account of their HIV. They are positive HIV. We have to treat them properly. Strict confidentiality of HIV positive AIDS information and privacy according to ethical standards and prevailing law. So we have to have the confidentiality and the privacy. HIV testing for purposes of healthcare should be offered routinely, but not compulsory, nor imposed over the patient's refusal. Practitioners and their staff members should be familiar with the most recent clinical guidelines for care of HIV positive pregnant patients and newborn children. Practitioners should take all precautions to protect themselves and staff from contracting the infection. Summary of the slide: a lady who is HIV positive or AIDS positive can get pregnant. She should have fair treatment, not inferior, to be equal to others. We have to preserve her privacy and confidentiality. We have to treat her, and we have to prevent the staff or the medical staff from getting the disease. We should not discriminate against individuals on the grounds of their HIV positive. That violates their human rights. HIV should not be discouraged from becoming pregnant, is what I have said. They can get pregnant. There will be an ethical conflict for us between the privacy and confidentiality to the lady and the need to protect the sexual partners. This will be a conflict. And as I have said, the one who got the disease or who is positive should tell the other partner. Antenatal care, we have to deal with it. Mode of delivery, we have to deal with it to deliver them better by cesarean section, for example, because less problem to the baby. Here about the baby, we have to prevent the mother-to-child transmission. The child is in the uterus. Blood circulates between the two of them. So there is a possibility of the child being delivered with HIV positive already. So there are certain precautions which we need to do to prevent the mother-to-child transmission, the one we call vertical transmission. In assisted reproductive technology, have to be looked into if she had a problem with it. Breastfeeding, yes. HIV treatment in pregnancy must extend into postnatal care. So here we are dealing with an HIV positive patient, what to do to her while during the pregnancy as an obstetrician. The informed consent, you will have it in the other part of the professionalism course. It's the consent obtained freely without threats or improper inducements, after appropriate disclosure to the patient of adequate and understandable information in a form and language understood by the patient. So you have to tell the patient all the information needed, the diagnostic assessment you did, the purpose and the method the likely duration and expected benefit of the proposed treatment, their diagnosis, purpose of your treatment, method of your treatment. You tell them that the alternative methods may be there. You can have for example, surgery, or you can have medication for that. And you tell them about the benefits of each and the risk of each. And accordingly, she will sign, the consent form. And here I'm talking about she, because in our situation, and you tell them about possible pain or discomfort about it. Information of the consent. This is for sterilization. I just talk about the previous one. In our situation here, the informed consent is not signed by the patient, as I have mentioned earlier. Unfortunately, it is the wrong practice. We are changing it now. We hope culturally we will be able to do it. The one who should sign for the consent form in our situation should be the lady herself. Whether that is an operation or whether that is a treatment, she is the one to sign. Unfortunately, for the social or for the culture in our country, the male partner will sign on her behalf. And male could be the husband, the brother, or the father. But ideally, she is the one to sign the informed consent. Nowadays, we are trying to push that in some hospitals, that we let them sign and could be countersigned by a male. But the ideal is the the female. Consent for sterilization. We usually give it. We have to sterilize some patients. She has to give consent, and the father or the husband should give consent, and they sign for that. The information we should give them that sterilization is not reversible. It is irreversible. Because some people may come to you and they say, نربط وبعد لما ادور عمليه افكه ثاني فك الربط. This is the term they use. It is irreversible. You tell them that alternative method exists for reversible forms of contraception. As I have said in the last lecture, whether there is going to have injections, intrauterine devices, implants, shariha, all these are reversible. So you tell them that this is possible to be used instead of sterilization. You tell them that life circumstances may change, causing a person later to regret consenting to sterilization. Life circumstances, for example, she may lose one or two of her children, car accident, a disease, whatever it is, and she needs to have more children. She is divorced. She remarried, and the second husband would like to have children. So she has to be aware of those. These are just examples I gave. You can give any other circumstances, life circumstances. That the procedure have a very low but significant failure rate. Vulnerable women tend to be sterilized without adequately informed consent. Well, vulnerable women who are sterilized without adequately informed consent include ethnic or racial minority. Ethnic group, they would like to sterilize them or to get rid of them. HIV positive, vulnerable, why should you sterilize them if you can treat them? Low income, poor patients, why should you? They are vulnerable, but why should you? Drug using women, she's an addict. Women with disabilities, as I have said earlier on, they have the right to have families. So all these are vulnerable women. They should not be treated by sterilization. They could have their pregnancy on, and it will be treated. The Declaration of Geneva, document adopted by the World Medical Association, General Assembly, 1948. Only 3 months before the United Nations General Assembly adopted the Universal Declaration of Human Rights, الإعلان العالمي لحقوق الإنسان. ده أعلنه برضو United Nations. واليونايتد الورلد ميديكال اسوسيشن عملت Declaration of Geneva. What is the Declaration of Geneva? You will hear about it. It is the duties in general, duties of the physician to the sick, duties of the physician to each other. دي الcontents بتاعته. Duties of the physician in general, if you read through it. Duties of the physicians to the sick, and duties of the physician towards each other. And in a nutshell, it is a physician oath. The declaration is a physician oath. The physician will say that he will not do so and so and so. Amended several times. Declaration of physician, dedication to the humanitarian goals of medicine. Declaration that was especially important in view of the medical crimes which had just been committed in the Nazi Germany. 1948 حصلت محاكمات النازيين لمedical experiments which tend to be out crimes against humanity, and the doctors actually were put on trial for that, and some of them were executed. So the Declaration of Geneva comes from that part to tell the duties of the physician in general and duties of the physician for the sick. They say it's a declaration, it's an intended update of the oath of Hippocrates, which was no longer suited to the modern condition. Historically, في قسم أبو قراط, oath of Hippocrates. In our country, when you come to the General Medical Council, Sudan General Medical Council, you will swear an oath, أدي القسم, and the oath is not Hippocratic oath, it is the Islamic oath for all physicians to do it before starting their practice. It is Declaration of Geneva is something related to it, just for you to know. Then we stop here. Thank you very much. This is about different issues selected, which you will meet in your practice as an obstetrician and gynecologist or as a medical officer, and you will get, you have to know what to deal with them, how to deal with them.